testing.
Hello, everyone. Hello. Thank you for the one hello back. I appreciate you. Thank you. Oh, there was two. Oh, I see people waving. Hi, Micah. Good to see you in real life. Hi, waves all around. Thank you for being awake. Now, my name is Gena Pemberton. I'm the Chief Diversity, Equity, and Inclusion Officer at Omnicom Health Group, which is a network of healthcare advertising and communications companies. So really excited to be the moderator today. And before we get started, I do know that this panel is the panel before you and food. And as I know about Black folks and the others in here, y'all like to eat. And there's nothing worse than being in this spot. But I'm going to ask you to bear with us. We have a great conversation coming. They told me I still have my full time, so your food might be a little delayed. But our discussion will continue to be robust. So I appreciate you all paying attention and holding back your hunger pains. So with that, let us get started with our panel, which is about deepening trust within Black communities for better health outcomes, which lands perfectly into the theme of what all the other panels have done so far today, is talk about the importance of community. And now we're here to talk a little bit more about the importance of trust. So first things first, I'm going to ask each of my panelists here. I got a whole gang of people. A gaggle of folks. And so I'm going to ask each of you to introduce yourselves, but keep it to like 30 seconds. And in case you can't tell, I'll cut you off so that we can get to the important questions. So Rashad, let's start with you.
Well, good morning, everyone. I'm Rashad Burgess. I'm Vice President of Advancing Health and Black Equity at Gilead Sciences, and we are responsible for leading our entire enterprise's work around health equity, which is really centered on three priorities. One is helping to enable access to life-changing therapies, delivering scientific innovation to reduce inequities, and igniting social impact for the communities that we serve. So we're using all 18,000 employees to have an impact on health equity.
Good afternoon, everyone. I am Petrina Martin-Cherry. I'm the Vice President of Community Engagement and External Affairs.
Is
your mic on?
Is it on? Is it on? Let's see.
Let me just use yours. There you go. Sorry. I'm the Vice President of Community Engagement and External Affairs at Boston Medical Center Health System. Boston Medical Center is the largest safety net hospital in New England. We serve 40% of all of Massachusetts' Medicaid population. About 80% of all of our patients are publicly insured or don't have insurance. So we have decades of experience serving people from communities, so not just our patients, but the communities that they come from, who have been for generations underserved. So our programs, we have excellent clinical care, but we also build programs designed to give access to communities that have been so long denied. And so community is first and equity is first in everything that we do. And my job is to connect public, federal, local policy, our corporate funders, and most of all, community-based organizations to the work that we do and making sure that community has a seat at the table. And I'd just like to take 1 second to say thank you, BDO, for creating this space. I have felt so amazing today. You guys know this work is very, very hard. It's hard getting people out of a mindset of charity and getting them to focus on equity for the communities we serve. So thank you, because this work is hard and it lives somewhere. I say that all the time. And so I hope you guys are all being filled today as I am. So thank you.
Good afternoon, everyone. My name is Kim Bellamy. I work at the Association of American Medical Colleges, or AAMC. For those of you who aren't familiar with AAMC, we are a nonprofit member-serving institution that provides guidance and leadership to over 150 U.S. and Canadian MD granting medical schools across the country, specifically in the areas of medical education, medical research, community collaborations, as well as diversity, equity, and inclusion. I serve within our equity, diversity, inclusion department and team and contribute to our programmatic efforts to advance physician diversity as well as health equity.
Good afternoon, everyone. My name is Kendal Whitlock. I am head of digital optimization in the real world evidence clinical trials team with Walgreens. Now, Walgreens you may know of as your corner store between happy and healthy. But 2 years ago, our then CEO, including our chief trials officer, Ramita Tandon, had a vision. I've spent the last 25 years in the pharmaceutical industry, and 13 specifically with one company prior to coming to Walgreens, but we have been talking about diversifying clinical trials for a very long time. We have done less to improve or eliminate those disparities. So I came to the clinical trials business because there are 3 service lines. One of them is patient recruitment. One of them is at-home clinical trials or digital, hybrid, decentralized clinical trials. And the third is real-world evidence. So in my role, I look at those gaps in digital access. I look at the assets that Walgreens has of 9,000 locations in the country, 7,000 of which have a private health room. There are clinical trial sites going up across the United States, so when people come in to fill their script, get their lipstick or a photograph, they also are stepping into the conversation at times for the first time to speak about clinical trial participation. As been said earlier, sometimes we don't have the access, but sometimes more importantly, we don't have the education. We don't have a trusted entity in our community, and the pharmacist is somebody we may see monthly. The pharmacy is a place where we are already familiar. And so by communicating with our community, we learn from the community and we can do a better job, we believe, than has been done by industry. And it's not a criticism of industry. It's just lack of skill in community-based participatory research and identifying community partners who we can partner with, who we are already talking to and have been talking to for 120 plus years. Nice to meet everyone. And thank you to BDO for inviting us.
Well, hello, everyone. My name is Veronica Sandoval. Is it not on? Okay, I'll take another microphone. Hello, everyone. Can you hear me now? Okay, my name is Veronica Sandoval, and first I want to thank BDO and the team for inviting me to this great event and for having such a great group of panelists up here. I think you're in for a treat. I am a principal in patient inclusion and health equity in the Chief Diversity Office at Genentech. I have the privilege every day to think about health equity. But most importantly, one of the things that I am very proud of for being at Genentech is that it's not just lip service from Genentech. We really think about health equity in everything that we do, from the design in our clinical studies, to the policy, to access, to thinking about those community partners. That our Chief Diversity Officer, Quita Highsmith, had the hindsight, the vision of thinking about when they're in 2020, when the Chief Diversity Office was formed at Genentech, to say, what are we going to commit to? So she made a 5-year commitment saying that by 2025, Genentech was going to focus on 3 pillars: fostering belonging, thinking about our own people, and thinking about diversity, inclusion, and equity, but also thinking about advancing inclusive research and health equity. You know, this was even before the FDA came to the table and said, all of pharma sponsors and non-pharma sponsors, you need to have diversity action plans. And Quita was like, we're gonna do that in 2020. By 2025, all of our molecule teams need to have a diversity action plan. And that is because you heard from the other panels during the day that equity needs to start at the beginning. And we at Genentech really believe that we need to start even earlier, even when we're having those conversations, right? And what can we do? And the last pillar is our transforming society. How and who are we partnering with, and be intentional with those community partners? Because you've heard the theme, we cannot do this alone. And we have to do it with trusted partners in order to be trustworthy of our patients and beyond that. So thank you.
Thank you. Thank you all for your great introductions. And let's get to chatting. So, as we talk about building trust, can maybe you give an example of how you might have built trust in your roles? Rashad, I'll start with you.
Sure. So, one, I just also want to say, BDO, thank you for this incredible
Oh, yeah.
convening.
Y'all, thanks. Thanks
Yes,
so much. Thanks.
yes. I didn't say it
I know,
first.
me either. I just got
needed
to
my mama taught me
interrupted about
always to be
lunch.
gracious
Right.
and say thank you.
You're right. You're right.
But I think a couple of things. One, we are leaders. We've been working in farm. We've been 37 years as a company, and we really have our bread and butter in HIV. Over 35 of those years working in HIV, and so we understand the importance of trust, the importance of having authentic partnerships with communities, because you can't, as was said earlier by Terry and others, you can't do work in HIV and not have community voices at the table. From bench to bedside, we have to be engaged. And so we at Gilead have learned a number of lessons over the years. And one of them I would put out there is that, as many of you know, that we're the #1 philanthropic organization in HIV. We give over $250 million around the globe to HIV causes. We're very, very proud of that work. But we also know that there have been some huge and significant gaps in terms of what's happening with HIV, where HIV is having some of the biggest impact. And so about 7, 8 years ago, we started to have a conversation about what's happening with HIV, where is it having some of the greatest impact, and we saw that it was really having that impact in the South. And so we made a significant commitment of $100 million over the course of 10 years to really make a difference in what's happening in HIV in the South. Impacting stigma, really ensuring that there are policies and advocates on the ground who can really change the lives of those impacted by HIV, and helping to ensure and enable access. What we have learned from that is the importance of consistency, the importance of sustained investment, and the importance of having partners at the table the entire way. And I have to also say, the importance of representation within the organization, because it's been Black and brown people key decision-making roles to help ensure that we were launching this in the right way, having the right impact with the right people.
Yeah, thank you for that. And I think Petrina, you shared a really great example when we were talking before about this. So maybe you can share your example at BMC.
Absolutely. So when our patients come into our hospital, we have a Thrive screener where we ask them questions about, do you want access to education care? Do you need help with finances? And, obviously the answers that come back are yes. We also have several community advisory boards that we actually listen to. We don't check a box with these boards. We invite them to the table and give them the understanding that what you tell us, we're going to use this information to inform the work that we're doing. And so one of the things that we kept hearing from folks in the community, especially in Roxbury, so let me just set the stage. In the city of Boston, there is a 23 life expectancy gap from the Back Bay, the affluent Back Bay, to Nubian Square, which is Roxbury. So we were like, well, why can people live to be 92 in Back Bay and they're dying at 69 in Roxbury? One of the things that we saw, there are many reasons, all systemic, you guys know them, all of them relate to redlining. But one of the things that we knew about Roxbury was that there was no, there was no grocery store, there was no Whole Foods, there was nothing like that. And so we decided we wanted to invest, BMC, a safety net hospital, not a mega for-profit hospital. What we decided that we wanted to do was to invest in a Black-owned grocery store in Roxbury. So we found 2 Black business owners who had been serial entrepreneurs. They had had these businesses before. One, his background was a molecular biologist. The other one was a Bon Appetit chef. So they had both owned restaurants before. So we invested $1.7 million into this grocery store, and then invited others to be a part of the capital stack to invest in this grocery store. And so it opened last year in May. What we did, a year before it opened, we started bringing in other business, people from the mayor's office, people from the governor's office, to make sure they knew that this was coming. We all needed to support it. We weren't going to put the money into it and walk away. We we engaged our marketing team to help them. So what we created, it is now beautiful. The food there is like fruit, vegetable, meat, like you'd find in Whole Foods. It is in a largely Muslim African neighborhood. It is the only halal butcher shop that is probably within a 50-mile radius of Boston. It also is fresh fruit cafe that, like, with a menu created by this chef, amazing, amazing food. It supports the ecosystem of the African diaspora because on the shelves are products made by other Black businesses. So what I'm saying is, here is a safety net hospital without a ton of money. We used our determination of need money for that. If you don't know what that is, if you do a capital bill, 5% of what you spend has to go back into the community. So that is what we did because we listened to the community. The other thing that we knew that is in the Commonwealth of Massachusetts, there are over 40,000 jobs in biotech that's not filled. You know, Boston is the epicenter of biotech. And we have community members who need jobs, who as a pathway to economic mobility were these jobs. So I started meeting with the leads of these biotech companies saying, what if we funded a training program? Not something that was like months old. Like, what if we funded a training program that would be 8 weeks or 12 weeks, and we built you a pipeline of community members who were vetted, you could come in and train, and they could have access to these jobs. Thermo Fisher, I know somebody from Thermo Fisher back there, said yes. And so we paid Jewish Vocational Services to help us, you know, to interview, get folks in the pipeline. We started a pilot program that was 12 community members out of 13 applicants. So they're out there, but we could only take 12 at the time. They went through 8 weeks of training. They knew before the training was over that Thermo Fisher was going to hire them. They are now all employed by Thermo Fisher, making $30 an hour, making drugs for multiple myeloma, gene therapy medication. So this is something that community members can do. Like, the talent is there, but the opportunities are not. So what we are doing is finding pathways to all of these opportunities.
That's amazing. I think, Kendall, I see you chomping at the bit. Do you have something to add as it relates? No. Oh, go.
Just excited.
Yeah, I know. Isn't this exciting? Trust is so riveting. All right. Says the moderator. Kim, do you have anything to add on this topic, or anyone else have anything to add on here? Yeah? Is it green?
It's not green. Okay. Hello? Musical microphones is what we're doing today. 2 disclaimers before I answer the question. 1, seasonal allergies are kicking my butt, so if I cough at any point, I promise I'm not spreading anything to anyone. I am in a room full of healthcare professionals, so hopefully you all can help me out. And then 2, I'm going to refer to my notes because we did have a discussion beforehand. I took many notes just to make sure I'm addressing all of the many things AMC is doing related to building trust within the Black community. So one of the first things I wanted to address that I neglected to address during the introduction is that we also focus obviously on patient care and preparing our future physicians to provide culturally responsive care to our community. So that is a key area that I want to emphasize that AMC is focusing on in terms of building that trust, is making sure that our future physicians have the tools, the experience, and the knowledge to be able to take care of our communities. One of the ways that we're doing that is through our accrediting body, LCME, requiring all of our medical schools to make sure that the activities that our learners and our students are engaging in are focused on community-based learning, community-engaged research, and that they are having that one-on-one interaction with the communities that they're going to be treating and caring for. So that's one area that I wanted to address. And the second is that AMC has also made it a pillar of importance that we're focusing on community collaborations, and that has been incorporated within our strategic plan. As a result of that, we've created what's called the Center for Health Justice. And the Center for Health Justice, and I'm going to refer to my notes to make sure I don't miss anything related to that. The goal of our Center for Health Justice is to collaborate with public health, community-based organizations, private sector, nonprofits, community leaders and community members to make sure that we're building the case for health justice through research, analysis, and collaborations that drive our efforts for the future. So as a result of that, there was a conversation in the previous panel about the difference between community outreach versus community engagement. One of the things that came out of the Center for Health Justice is a community engagement toolkit, which various different health organizations, institutions can utilize to really give them that framework and foundation of how to best engage the communities that they're serving.
Kendall?
Yes.
Nothing to add on this topic. I have more questions.
Yes, no,
so
I
hit us
would love
anywhere.
to just chime in. A couple of things that we have done. So as I mentioned, the clinical trials business started in June of 2022, so not very long ago. So you can imagine to go from an N of 1, the chief trials officer, to now over 70 employees takes writing your SOPs and training people, getting them up to speed. But some of the things that we're particularly proud of is, one, a partnership that we have just launched to begin to train our pharmacists so that they are GCP trained. If the pharmacist can be the conduit when the community has health disparities, then imagine being able to get a question answered. You may not know that clinical trials even exist. Your healthcare professional that you go to may never have spoken to you about clinical trials. We are actually doing surveys, just a small aside. We did one for for International Women's Day. We also just did one, the Community Health Action Talks, is a part of an entire program, starting with a survey. But in both of those instances, we're seeing 87% of people have never had a conversation before about clinical trial participation with a healthcare professional. 87% of people. If that's the case, then talking to another healthcare professional might be the bridge to start the conversation. If you are filling prescriptions, and we can identify, we've done over a dozen trials, there are 25 in the queue that are in different stages, different therapeutic areas scheduled to launch. But if we can be the conduit to the beginning of the conversation, then that individual can take that conversation back to their healthcare professional. And then this is an avenue for education about what clinical trials are, both in-person, in-store signage you see, not only the advertisement for whatever the awareness campaign on the health promotion calendar, but what about seeing signage, whether you're at the drive-through, whether you are in the back of the room in the private health room, whether you are on the counter picking up your prescription and seeing a brochure with some of the data that the community is sharing with us about their interest in clinical trial participation and their absence of connectivity to healthcare professionals who are trusted entities in their community that may look like them. That matters to some people, especially in Black and Brown communities, as we've already heard from earlier panelists. I'll stop there in the interest of time.
Thank you. Veronica.
Well, I'm excited because I get to pull through everything that has been touched on. And one of the things that I heard a lot was, and even from the prior panels, are our social drivers of health. All of us know that it's in the literature, and I'm preaching probably here to the choir, that 20% of outcomes are dealt because of medical access. But the other 80% is due to social drivers of health. We just heard about food insecurity, and what the great job that you're doing with your community and building a grocery store where there's a food desert. But what else can we do? So at Genentech, one of the things that we get to think about is even 4 years ago, when we were thinking about how are we showing up to our communities, so we redid our entire way of engaging, and then not only doing that community outreach, but that community engagement, and that was driving everything at the local level, because all of us know, I live in the state of Washington. The care, and even when I talk about the state of Washington, I don't live in Seattle. I live in a tiny, small rural area that my mom is like, how did you end up there? I said, Mom, it's beautiful, right? I'm surrounded by nature. But nevertheless, the healthcare that I get in rural Washington is very different from the healthcare that you are receiving in Louisiana, in South San Francisco, where Genentech is, and other parts of the country. So one of the things that we have been pushing out is driving local community engagement to drive better healthcare outcomes. And that is because everyone knows what those issues are of disparities at their local level. An example is, how do we engage with our Black community, our Latino community, our Native American communities? And that is by listening, having a seat at the table with diverse stakeholders. And I heard policy. Policy is such a huge piece that I think all of us, if there's a call to action today, is like, how can we continue working with our congressional members, our local elected officials? And I'll give you an example. My colleague Jackie Ingram in the past panel mentioned the American Diabetes Association partnership that we have in the work that we're doing to advance eye health care awareness. One of the biggest things that I heard even previous panels, know your numbers. All of our families know their A1C numbers. If you tell them, they will know. But one of the missing links is, what are the chronic conditions that happen because of diabetes? Vision. Vision loss should not happen. There are treatments to delay vision loss. But our communities do not know that they should have an annual exam. So that is what we're doing with the American Diabetes Association, and that's what we did at in Birmingham, Alabama. In partnering with the ADA, partnering with the University of Alabama, community members, we actually brought over 100 community organizations to help us amplify, and increase that education in a culturally relevant way. But also bringing in congressional elected officials with the Congressional Black Caucus to hear, listen, be part of the conversation, because they need to be made aware of the issues so the better policy can happen. We heard about redlining. That is an issue. One of the things that we talk about at the Chief Diversity Office is that we need to stop blaming the patients for their outcomes. And we need to meet patients where they are. And that's what we do with even representation in our clinical studies. One of the biggest things that we want to do is how can we take those clinical studies not to the Ivy Leagues or the typical clinical sites that we always go to, but let's take them to those community centers. And the best example of that is with our multiple sclerosis program. We actually partnered and had the patient voice be part of the protocol review, have neurologists that treat patients of color to give us feedback in those protocols. Then think about, how are we going to engage and remove those barriers that patients face, from financial toxicity to transportation, in order to ensure that patients can have a really good chance of making it through a trial, not only being enrolled, but being retained through the trial. So we actually enrolled in a multiple sclerosis trial, a phase 4 trial that focused on Latino and Black patients 2 months early. And we had patients on a wait list, patients raising their hand. So this goes back to myth busting. When there is people that say clinical studies with underserved patients cost more money and it takes longer. Well, it doesn't. And we've shown it, and not only shown it in multiple sclerosis, but in diabetic eye disease, COVID-19 induced pneumonia. And now we're trying to think, how can we make this as part of the work that we're doing at Genentech?
Yeah. Thank you for that. So, what that kind of brought me to a thought about, what do we do with, future healthcare professionals, and how do we start to get them to start thinking a little bit more about how they can build trust? So one of the questions, and I'll start with you, Kim, since you kind of are in the world of reaching out to our future healthcare providers, how do we start to get them to understand the importance of building trust? Or what are some things that maybe you all are doing at the AAMC, or maybe what do you suggest that we could be doing to drive the future professionals?
Yeah, thank you for that question. So in addition to what I shared earlier, just around the general medical education training, for our future physicians, we also implemented with 2022 diversity, equity, and inclusion competencies that we are making sure that all of our medical schools and academic health centers are aware of, and making sure they're incorporating into their curriculum. so that our future physicians are prepared in that way. Some of the goals of those DEI competencies include engaging healthcare professionals in collaborative discussions around DEI that's not only across continuum, across the medical education continuum, but across disciplines. So not only within medical education, but other healthcare sectors as well. It looks at a gap analysis of the local curriculum and training programs to see where are the areas in which we can really enhance our emphasis on DEI and making sure that, again, our future physicians are providing culturally responsive care and really have a understanding of those that they're going to be treating. Doing self-assessments and planning individual professional development, developing curricular learning objectives, and then finally, we also introduced an anti-racism framework to address systems-based challenges within medical education. So it's not something that we're just talking about, but it's being ingrained within the curriculum that we're teaching our students.
Can I add to that?
Yes,
Sorry,
please.
Rashad. One thing that we are telling both our residents, our student doctors, and even some of our practicing physicians is that whatever diagnosis that patients are getting, that is probably not the worst thing that is happening to them. That is not the thing that is priority, even if it's a cancer diagnosis. So to make sure that we are getting to know our patients, getting to know what their experiences are, so that we can help them with whatever it is. So whether it is financially related, whether it is like somebody is the judicial system involved, so we can help them with those issues so that they can have a sense of peace, lack of stress. So then they are adhering to whatever the medical process is that the doctors are getting them to adhere to. In the space of research, so BMC is one of the top 20 NIH-funded institutions in the country. So, and we are in Massachusetts, where there are a lot of opportunities for research. And so we believe that there is an extreme importance in community-based participatory research. We know that we need to be in these clinical trials, all of that. So I am kind of, I think I get the nickname of the gatekeeper to the community at our hospital, because no matter what department you're in, if you want to touch the community, you come through our department, because trust is hard to build and easy to lose. And so we have a tremendous amount of trust in the community, and it's my job to make sure we keep it. And so often when researchers come to us and they have whatever research thing that they want to take out to the community, my question is, what have you done in the community? Like, what has your department done? Because we can't show up with a syringe and a clipboard if you haven't shown up and built a relationship. Yeah. And so we have to make sure that clinicians spend time in the community. So yes, you can go off the trust of the institution, but do they know you? And if they don't know you, you haven't spent enough time in the community to go in and ask for research. The other thing is to make sure that we are creating spaces for education and research. Community members should know what things they should be considering research on, and they should be given an opportunity to make a decision. And so yes, it's important, but they have to be educated, and it has to not be transactional. So.
Yeah. Pick up on that
Yep.
for a second.
Rashad, did you want to add something? I thought I saw you jumping in.
Absolutely. So a couple of things. One is that something I'm really excited about that we're doing at Gilead is actually having some of these hard conversations about stigma, about bias with actual providers. And so we actually have over just shy of 50 HIV community liaisons who are working every day in communities, Black, brown, LGBTQ communities. And what we discovered was that many patients were falling out of care, are not getting into care, and it was because of the bias that was taking place inside of the provider office. Now listen, us in pharma, that typically is not the issue we're looking to address, but it was getting in the way of patients actually having access to care. They could get the medication, but they can't get the medication if not seeing a provider. So we had to do real work, and so we brought an entire series called Culture Humility in Healthcare, working with over 1,300 organizations across the country, taking not just their providers, but their entire team through a series talking about the importance of building trust with patients, the importance of understanding distrust and mistrust, and the importance of understanding patient-centric care. Because what was happening is that oftentimes providers in the healthcare provider system was treating patients as if they were the problem, not understanding how they were contributing to how their patients were not accessing care. The other thing I would say that I'm really excited about is the way in which we are working with community influencers. So often we know the importance of celebrities and influencers in Black communities is very real. And often there's a tension around us in industry showing up. And so we decided we're going to break through barriers and actually working with influencers. And so we did an entire testing initiative with Raheem Devon, many of you know. Well, there we go. Someone said, of course.
He hits all those notes.
Come on, he does hit the notes. And so we developed a partnership with him to really ensure that we're bringing messages around HIV and the importance of how HIV is impacting Black women. And so we actually reached 36,000 Black women and partnered with organizations across 18 cities to really develop that connection between how social influencers and celebrity influencers can be key messengers on key populations to really ensure they're getting access to care. And so really proud of that work.
Yes, as you should be. That was great. And any other pieces? Veronica, go ahead, and then I'll come to you, Kendal.
I just want to also add that it is great that we have the influencers. It is great that we're going to have the next generation of doctors and physicians being trained. But one of the things, I don't know if many of you knew the late Dr. Edith Mitchell. And, we were so fortunate at Genentech because she was part of our external council for advancing inclusive research amongst other great leaders in this country. And one of the things that she always told us was, Genentech, you need to call things for what they are. And that was systemic racism in our healthcare system. And she was a big proponent of, for the role that Genentech could play in ensuring that we dismantle the implicit bias and educate even our own physicians. And that includes everyone, physicians of color, white physicians, any color of physicians. Because when that patient comes through the door, there are implicit biases that a doctor makes a decision for the patient of not offering clinical trials, of not offering a new innovative medication because of insurance costs or whatever that be. So how can we as an industry continue educating? And that is something that I'm very proud to say that at Genentech we do and we're taking very seriously. We founded in 2021 the Advancing Inclusive Research Site Alliance with the City of Hope in LA, the Mace Cancer Center in San Antonio, the West Cancer Center in Memphis, Tennessee, the University of Alabama in Birmingham, and then added Montefiore and the University of Illinois in Chicago in oncology. And we also expanded outside in ophthalmology. But the idea is, how can we bring these centers of excellence to help us think through the different ways of dismantling systemic racism in the healthcare system in order to reach the patient, but also bring in that patient voice. There are some very strong stories from our patients that we have been told multiple times. These are Black women going to their oncologist, to not even their oncologist, the primary care doctor saying, I have a lump. You're too young. They're dismissed. It's triple negative breast cancer. It's their lives. So how can we bring that patient voice and have more physicians hear the patient, hear their struggles, understand the patient journey? Because that's how everything is going to start and end. Because at the end of the day, all of us here are patients. So all of us want to have equitable health care, but we need to, as an industry and as colleagues, cross different functions. We need to figure out a way as to how do we keep elevating these issues, but not only talking about them, so we're not here in 20 years and still having the same conversation, but what are we going to do to drive actual change, to dismantle these barriers?
So 2 quick points. The first, I want to acknowledge a panel that the White House hosted last January on emergency preparedness for clinical trial participation because of the hesitancy, and it was discussed by Dr. Tuxson earlier on that panel, of people not thinking about getting the COVID-19 vaccination. And my boss, the Chief Trials Officer for Walgreens, Ramita Tandon, participated as one of the experts in that panel. Well, when I spent the last 20 plus years in industry, we did clinical trial simulations for the trials that we were about to conduct in order to sort of work out the kinks so that we knew how things would function. And this was particularly important with decentralized clinical trials because the clinician investigators were often not familiar with the use of the digital form of a test or the telemedicine consultation or any of the other elements of decentralized clinical trials. So who was absent in industry when industry learns how to do the trial process? Patients and people from the community are not involved in clinical trial simulations. So one project I want to highlight is something that Walgreens is working on with the FDA and the University of Maryland Baltimore School of Pharmacy on designing a clinical trial simulation experience. Because imagine if we can go in our community and we can go and know that CPR certification is available to us in communities, then why can't we go to our community and get training on clinical trials before we need to participate in a clinical trial? If we were building a house, we wouldn't wait till the day we're starting to build the house to learn how to build a house. So if we expect that medicine is going to work for us or that medical products are designed with us in mind, we have to be a part of the process. We can look at inequities in the prevalence of diseases and say, oh, those are all social determinants, or a majority of those disparities are socially determined. Then we can take ourselves out of the equation if we want to and continue to say Henrietta Lacks, Tuskegee, or we can choose to empower ourselves with the process and knowledge about how to participate in the clinical trial when we walk into the door of a Walgreens store and find the healthcare professional to have a conversation with and learn more about the process. So that was the first point. The second point I wanted to quickly make was a piece of literature that any of us can go to Google right now and find. The first author is Stallings, Sarah Stallings. The last author is Consuelo Wilkins. I want to highlight this team of investigators because this is work on a validation of a scale called the PORT, it's the perceptions of research trustworthiness. This is a panel about trust. And what these authors and investigators identified is that trust is not one thing. Let me repeat that. Trust is not one thing. So that means that what these authors found was that in the participants who were white, they had different factors that they associated with what is trustworthy in research. Hispanic and Black tracked together with what factors they had in common in what they believed attributed to the trust they would have in research. So just as we talk about diversity, it's not just race and ethnicity. People in rural communities have different healthcare experiences than people in urban communities. Men may have different experiences than women. Older adults may have different experiences than young adults. We have to be specific and accurate when we talk about trust. And if we don't know that trust is not one thing, then we have to get to know. What is trust to you? What is trust to you? Trust may be different for you than it is for me. And it's important if we're personalizing medicine, all of the AI in the world can prepare us for more personal and specific forms of medicine. But if we are not aware and our clinicians are not aware of what works for us, we will never have personalized care for ourselves or our communities. And I'll stop there.
Just drop the mic right
I'm just going to say, Dr. Wilkins and Dr. Stallings,
right.
just look at their work.
Facts. Thank you for that. So I'm going to start to wrap us up. So I have my final question is, what is the one thing you want people in here to walk away with? And I feel like Kendall kind of dropped hers already. But I'm sure that she probably has another gem in there as well. I'm going to go ahead and start with you, Dr. Petrina.
One thing. I'm going to steal a story that Michael Curry uses all the time. Michael Curry is my dear friend, and he closes out a lot of his conversations by saying that somewhere in Roxbury, Mattapan, name your urban area of your town, there is a little girl. And within this girl is the cure for cancer, it's the cure for the drug trial that you have. Within her is everything that we are looking for. It is our responsibility to kick down every door, to provide every level of access we can so she can walk through those doors and get to Meharry, get to wherever she needs to get get the education and the access that she needs to be able to do and to solve the problems that we are trying to solve. And every day, that is the thing that drives me. I started this off by saying how hard it is some days. I love my job, but some days I just hate it. And Dr. Thea James, who is my colleague, is right there, and she is the person that I call when I'm so tired of trying to get folks to understand the level of talent that we have in these communities, and we dismiss them because they're poor without thinking about how they got to be that way. And so I think about that little girl, and it drives me to like go to one more church and have a conversation, to sponsor one more community advisory board, to sit on one more board myself. I sit on 5 or 6 boards, like the Boston Foundation, because that's where the money comes from. And so they need to hear my voice at the table. So when they're making decisions about what money needs to go into the community, I can be the voice of the community at that table. I sit on the board of the Boys and Girls Club. That's another anchor institution. So I'm hearing from teachers and from parents what's going on in that community. So I would just encourage us all to remember that little girl, that little boy that we are doing this work for, so that they have access to change this country, to change how we are receiving our health. And that's what I'll leave us with. So thank you, Michael.
Thank you.
Said much better.
All right, Kim.
Yes, so one thing that I was thinking about as I was hearing from my colleagues up here is also building trust through increased representation. Creating a more diverse physician workforce, that's definitely going to be one of the primary ways that we'll be able to build trust, because there's research that backs that if you're able to be served by a physician, with similar experiences, identities as you, that you have a greater chance of having access to care. Your satisfaction of the care you receive will increase. You are more likely to follow through on any treatment plans and things of that nature. But we also know that in terms of representation of Black doctors within the physician workforce is, just above 5%. Is been around that percentage for some time now. So I am, and my organization is doing all we can to increase representation, not only of Black physicians, but across the board to increase diversity. But until that time, making sure that, again, if we emphasize and really put a focus on improving our medical education and training, making sure that all of our future physicians across the board really has a distinct and a depth in terms of how they're getting to know their community, really looking at it from a holistic perspective of all the many things that they're bringing into that exam room when they're coming to be treated, that I do believe that we can see some changes that we want to.
Awesome. Rashad.
The solutions are with us. And I think that we have the power in this room and in the institutions to really change lives. And it is hard. I was with my team the other weekend. I said sometimes this work is unsettling at times because it's just so hard. But what's also true, someone talked about the gospel, there's really good news. And I see that even though DEI is oftentimes under the attack, there is an invested interest that all of our companies have to really ensuring that we change these health outcomes for communities that are so often left behind. And I don't know about you, but I'm really inspired by the fact that business, academic institutions, and so many others are starting to see and realize that they can't win and leave us behind. So
That's great. Veronica.
As I was listening to everyone, I was reflecting, like, what story am I going to share to leave you with? And, I love the fact that all of us are saying, how are we going to increase that pipeline, ensure that the next generation has those doors that are opened. And I want to leave you with a story that our CEO from Genentech shared, Ashley McGargy. And, because every time that we have a new leader at Genentech, they give their journey line. And in her journey line, there was a story that stuck with me. And I hope that it's something that you could take away as to where Genentech is coming from as we're trying to build a more equitable healthcare for this country. You know, Ashley shared that when she first started, she was actually a principal in the Bronx at a school. And she would walk across the street to the kindergarten school, the room, because she felt at ease. But one thing that she noticed was that some of these kindergartners, you know, sometimes they would not show up. And even though, you know, she knew that a good education was the key to be raised out of poverty, some of those kids that did not show up, you know, they would come back. She would try her best to tell the teacher, stay long hours after school, let's bring him up to speed. They were brought up to speed, but then again, they were out of school. And it was because of cystic fibrosis. So one of the things that she vowed to was, how can she make it her life mission that every child in this country has access to equitable healthcare? So now as the CEO of Genentech, she really believes in health equity and ensuring not only children, but everyone has access to innovative medications. So because without our health, we cannot open those doors in order to ensure that the next generation of scientists, engineers, computer scientists are going to help us make sure that we have that representation that we need, because it's not going to be too far from now that this country is going to be a minority majority. Some states already are. So how can we ensure that we are part of the solution and that our needs as a community are listened to, and that we are no longer a selection in a menu, but we are driving that menu in this country?
Yes, definitely. Kendal.
So I'll share a little bit of personal insight about me. When I was in graduate school the first time, my father was diagnosed with non-small cell lung cancer. And as a graduate student, I was terrified, but I was also in a position to learn a little bit about how his disease was being managed. And I could accompany him to doctor's appointments, knowing that he was terrified whether he told me he was scared or not. My parents were divorced and he was alone, and I decided that he should not be going into those settings by himself. So for my father, and in the experience of his journey, I learned that 75% of non-small cell adenos succumb within the first 3 years. Well, my dad became the subject of grand rounds in his 9th year with this diagnosis. And they were confused about how he was as healthy as he was for as long as he was. And I likened it to the lessons that I learned in middle school from my health education teacher, Miss Johanna Wright from South Orange, New Jersey, who taught us about esophageal cancer as 7th graders and the consequences of smoking. And he had a 2-pack of Winston a day habit before I was born that probably had something to do with the later diagnosis of lung cancer. Well, as a kid, learning that in 7th grade, I crushed the cigarettes and I hid them in the bottom of the closet so that he couldn't find the last little cigarette. Or I found them in his coat pocket after he came home from work, and we had long been in bed, but I waited up so I could sneak in his coat pockets and steal the cigarettes and put them in the trash or put them in the back of the closet like, I don't know where your cigarettes are, Daddy. So that was my first foray into knowing the power that I had to affect change that I learned from Mrs. Wright in the 7th grade. Fast forward to being in graduate school again, and I see a prescription, and I'm not disclosing personal health information, so I'll stop before I give too many details, but I saw a prescription in the medicine cabinet for a molecule that I worked on for 5 years as a medical science liaison early in my career. I called my sister, who was living in California at the time, and I said, our life just changed. I need you to move back because I can't do this by myself. I moved my mother into my house 10 years ago. I have been the primary caregiver for a person with a diagnosis of Alzheimer's disease. And in my work, it's not a job. I've spent my career learning everything I can from my parents and my family and my community, because I don't see people breaking through doors, making sure that those conditions are treated equitably and that their experiences in care are fair and they have no biases that they're met with in the setting when there's a determination about clinical trial participation and one individual says, probably not reliable, I'm not even gonna invite this person. 87% of people have not had a conversation with a healthcare professional about clinical trials. I came to Walgreens because Ramita Tandon had a vision for what is possible right in our community. And so every day, I don't go to work, I go and get down. I'm going to get busy. There is work to be done. And I learned that as the chief trials officer, I can be the chief love officer in my family. And any person in this room, I don't care your color, your race, your creed, your orientation, you can be the chief love officer for your people, whether it is your biological relative or some stranger. You can be the voice of change for that person. And so I encourage all of you to be the chief love officer for people you know now and people you may know in the future.
So I'm going to wrap up our panel. I want to say thank you to these fantastic panelists. I think they've done a great job of talking about the importance of trust. I think we have brought the church as well to this stage. I mean, it got here a little bit earlier, but I think we closed it out. We're near the end. And I think right now we're about to go into the grand hall to have some food, as you do at the end of church. So I'd like to say,
make an announcement?
Yes, there's an announcement.
I have one announcement to make. So if this summer, if you're going to be on Martha's Vineyard and you're going to miss Ricky's Bougie Weekend the third week, but you're going to be there the first week during the Martha's Vineyard Film Festival, every year Boston Medical Center has hosted a health equity summit. And so this year we're back again on the 6th with a men's luncheon on Black men's mental health. And so both panels will be moderated by Simone Townsend from MSNBC. We'll be at Union Chapel on the 7th with a conversation on economic mobility as a pathway to health equity with Dr. Khalil Gibran Muhammad and the folks from Earn Your Leisure and some other amazing people. So if you're on the Vineyard, check us out.
Well, that's great news, because I am a bougie black. And so I will be there that particular week, but not the third week. So thank you, everybody. We're going to wrap this up.
Ladies and gentlemen, real quick, just a quick announcement about lunch. Quick announcement about lunch. If you can exit to my left, your right, and enter on my right.